Thank you, Mr. Kaur, for the kind introduction. Today, I'll be sharing on simple everyday urodynamics that we can perform in the clinic to help you assess your patients and also hopefully manage them better in the primary care setting. I think the dilemma whenever we're managing LUTS is that it is the predominant urological complaint, but actually LUTS is just referring to a standardized terminology of symptoms, which are broadly grouped into either storage symptoms or voiding symptoms. These were previously termed prostatism, but because LUTS can be seen in male and female patients, it has become disused in recent years. Because it's a constellation of symptoms with different causes and each requiring a different form of treatment, it becomes a difficult thing that we need to accurately diagnose and treat LUTS. So extra steps such as the urodynamics are usually helpful to help us determine which of the causes are present and which one we should treat. The classical approach would be to take a detailed history and also a detailed physical examination. Subsequently, we commonly use symptoms questionnaires to assess the severity of their symptoms. And if needed, we can perform some laboratory studies such as a renal profile, PSA, and of course, imaging and endoscopy if we need some structural information. But as you see here, urodynamics is actually usually fairly low down. We use it for functional evaluation and only if needed. For the symptoms questionnaire, of course, we can use IPSS for lower urinary tract symptoms, the ICI-QSF for any incontinence, and lastly, a OAB version 8 for overactive bladder. But these symptoms questionnaires have been shown that to not be adequate to diagnose either bladder outlet obstruction or even overactive bladder. And so this is when urodynamics becomes vital in the management of lower urinary tract symptoms. So it is commonly needed when we have a patient with persistent symptoms after we have started treatment, or there's a combination of symptoms that are not attributable to common diagnosis, or if the treatment that we are offering is either invasive or carries a high risk. Sometimes there are patients who are a bit more demanding. They want to have a clear diagnosis before being started on treatment. And this may be useful as a way for us to reassure them that we're treating the correct condition. So what is urodynamics? It's just methods we use to evaluate urinary tract function. So we are converting all these function into objective data that we can use and perhaps try to make sense of the patient's symptoms. They can be very simple observations, or it can be very precise measurements using sophisticated instruments. What we want to do is just to understand what happens when the bladder fills up and what happens when the bladder is empty. And to perform a proper UDS, or what we call pressure flow studies, it's actually very invasive. We have to insert catheters into the bladder and also the rectum, and we have to instill fluid into the bladder and chart the pressure change as the bladder is being filled. And when the patient has the urge to urinate, when they're urinating, we are recording the pressure as they urinate into a flow meter. The common misconception about UDS is this is the only way, the invasive urodynamic. These are very costly and very complex. You need a special setup just to have this test done. And in the end, you'll get a chart, something similar to this, which is what we call the urologist's ECG, which is fairly difficult to interpret if you're not familiar with it. So in the primary care setting, I would think that it is close to impossible to have this done or to even have a setup like this. So what we can do is that we try to emulate what we wanted to find out from the urodynamics. So what we want to know is the storage function. Can the bladder store urine at a low pressure safely? And also the voiding function. Can the bladder contract and expel the urine? When they're expelling, is there any obstruction to the flow of urine? And can the bladder empty fully after urination? So instead of having one test to determine all of this, we can have a combination of simple tests that we can take in clinic, which can also give us almost similar information. So perhaps the first one we should go through is the storage function. So the component that we want to emulate is the cystometry part of urodynamics. This is the part where we are filling the bladder, and then we want to test how much urine it can hold, the pressure as it fills, is there any involuntary contractions, and also when the patient has a sensation and also urge to urinate. This is very useful if you are trying to determine the cause of frequency and urgency. It may be a simple complaint like, doctor, I keep having to go to the toilet. So we want to know, is the patient producing too much urine? Is the bladder having trouble holding on to even small amounts of urine? Or it's just perhaps something psychological? So this will actually help us determine the cause of his or her storage symptoms. The most useful and simplest of all, in this case, would be a bladder diet. It's just a natural record of the bladder function, minimum for 24 hours, but ideally, if you have 3 consecutive days, it will give us a clearer picture. It's very simple to chart, just a time, amount, and what they are drinking, amount of urine passed, which should be measured using a simple cup, or if there's any leaking or any urgency. So you don't really need to have complicated records, just this are enough. So what are the possible findings you might find? So if with a bladder diary, a normal frequency and normal volume would be around 8 times or less per day when the patient is awake. And the normal volume per void should range around 200 to 400 milliliters. This is what we call the functional bladder capacity. So if there's increase in the frequency, but the functional capacity is the same, this indicates that there is an increase in the 24-hour production of urine in the patient. So these are commonly seen in habitual polydipsia, or they have diabetes mellitus, or insipidus. So what if there's increase in frequency, a reduce in volume, but there's no variation in volume? Meaning they are frequently passing small but consistently similar volume of urine. This indicates a fixed reduction of the bladder capacity, and usually is seen in inflammatory disorders such as TB bladder or interstitial cystitis, or perhaps they have a carcinoma in situ of the bladder. When it comes that they have increased frequency with reduced volume, but a variable volume each time, the bladder contracts at variable volumes, and this is usually indicative of an overactive bladder. When there's increase in nocturnal production, defined as a total nighttime urine together with the first morning void exceeding 1/3 of your daily total, this is indicative of a nocturnal polyuria, which can be contributed by cardiac failure or an obstructive sleep apnea. So let's see the chart that I have of a patient. You can see that the patient is drinking fairly reasonable amount of water, but passing frequent, small volume, variable, with a lot of urgency and leakage. So this is most probably a case of overactive bladder, and we can confidently try treating the patient with some antimuscarinic. Another way of performing a cystometry would be what we call Pulmons Sysometry, which is also known as eye volume cystometry. So we are comparing the intraventricular pressure with the volume instilled to assess the storage function. It's a very simple test requiring very few instruments, probably a 2mm syringe and a Foley's catheter. So after emptying the bladder, you can insert a small catheter, 12 French is more than enough. You remove the plunger from the 2mm syringe and connect it to one end. Then you slowly fill the bladder with warm saline and observe the level of fluid in the syringe, and also observe for any leakage of urine. For this procedure, no chart is generated, so it's all by observation and communication. And the things you want to know during the procedure will be sensation. Ask the patient, where is the first sensation to void, which is around usually 90 to 200 milliliters. Any fullness, which comes about 2 to 400 milliliters. The capacity of the bladder, which is defined as a maximal capacity, where there's most severe urgency, usually comes normally at around 3 to 600 milliliters. Stability is a bit more difficult to see on eye volume cystometry. You just have to look for any reflux of the fluid or a slower flow of fluids into the bladder. So it indicates a rise in the pressure or a contraction in the bladder. Compliance is difficult. As you instill, if even small volume, they start to slow down, you know that the bladder compliance is probably poor. But this is a bit difficult to perform because usually they are not very comfortable. So if your patient is relaxed, they understand what is needed of them, perhaps it is possible to do it. The second part of urodynamics that we may want to know will be the voiding function. So we're trying to emulate the pressure flow study. So a pressure flow studies the bladder's pressure required to urinate and the flow rate when there's a certain pressure generated within the bladder. What we usually do in our urology clinic would be a uroflowmetry. So it's a measurement of the urine flow speed and also the volume. Then we have a chart like this, which charts time over the flow, and we can get the maximum flow rate, average flow rate, time to void. From this, we can see some patterns that we can try to make out of the chart, and each indicating a different diagnosis. If the first one, you see a bell shape, it's fairly normal. Then you have the tower shape, very high spiky pressure, which is probably overactive. A flattened or prolonged shape, which indicates some form of obstruction. When there's a staccato, indicates probably dysfunctional voiding. And interrupted flow, which usually indicates underactive bladder. These are all very subjective, and it's difficult to have it done consistently, and even the same patient may have different readings on the same day. The machine itself is not cheap. The cheapest one that you can find online is probably around 2,000 to 5,000 ringgit. So are there cheaper alternatives available? Of course. One will be the visual uroflowmetry. Instead of asking or measuring, you just ask the patient how far the urine can go. Then it's just a tick on a piece of paper, cheapest you can get. Another one would be probably what is also known as eavesdropping uroflowmetry. Just listen to the patient's urination to see if there's a waterfall or there's a dripping faucet. So that's another way. But of course, it's quite unnatural for a doctor to be trying to eavesdrop when the patient is passing urine. So what you can do is there's actually an app, what we call a sonar uroflowmetry. So they're trying to estimate the flow rate from the sound recording using a mobile phone. And this is actually FDA approved. It's just that you have to pay for it if you want to use it consistently in your clinic for your patients. It has been shown when compared to conventional uroflowmetry, there's a 99.3% correlation. It also enables home monitoring in a more natural environment where the patient doesn't have to wait and the patient can pass urine in somewhere he feels comfortable in, which is very important to have an accurate result. What about instead of measuring flow rate, we try to identify the possible causes of obstruction, such as an enlarged prostate, or detect the sequelae of a chronic flow difficulty, such as measuring the bladder wall thickness or the postward residual volume. These are all possible with just an ultrasound. So if you have an ultrasound in the clinic, it's really easy. Normal prostate is around 20 grams, but estimating the size will not only help you identify the cause, but also determine if you can start other forms of treatment, such as an alpha reductase inhibitor, which needs a certain size to be effective. So the prostate volume is a multiplication of the height, length, and width measurement divided by 2. Fairly easy. So if you have an image like this in the axial and also the sagittal view, you just have to take measurements of this. Bladder wall thickness normally is around 4 mm. When it's fully distended, it becomes a bit thinner, around 3 mm. But when it's undistended, the bladder wall can be as thick as 5 millimeters. So a thickened bladder wall indicates a chronic obstruction, so you have to look for other things as well, such as diverticulum, stone, or maybe a dilated ureter or kidney. So you just have to measure 3 points in the bladder and take the average, and you have the bladder wall thickness. And this image shows a diverticulum in the bladder with a very narrow neck. Lastly, postward residual volume. Anything less than 50 ml remaining in the bladder after passing urine is normal. If they're a bit older, they tend to have a bit more, up to 100 is acceptable. A significant PVR signifies possibility of bladder failure or potential risk factor for retention and other sequelae. So the post-void residual volume is again a multiplication of three measurements, then multiplied by 0.75. So this is the bladder in the axial and sagittal window. Just take three measurements. And the volume here is 138 ml, which is increased. So can this test replace pressure flow studies? Actually, there has been a study on non-invasive uroflowmetry, non-invasive urodynamics in the assessment of lower urinary tract symptoms. And what they found was that it's 94% predictive, and it correlates with the invasive urodynamic study 89% of the time if you use a combination of prostate volume, bladder wall thickness, and also the post-void residual volume. So I think the take-home message is that urodynamics does not always have to be complicated. Simple assessments you can done in the bedside, in the clinic, with just an ultrasound can yield very valuable information. If your patients mainly have storage symptoms, such as urgency or frequency, get a bladder diary done. I think that will be good enough. If they have poor voiding, either a visual or sono-uroflowmetry with sonographic measurements, as mentioned earlier, will be useful. And all this will help us understand our patients' complaints better, and hopefully we can manage them more effectively in the clinic. So I thank you for your attention, and I'll be happy to answer any questions during the Q&A session. Thank you very much.